I will be moving in to give the next talk, and I'm going to be speaking about ultrasound for pelvic venous disorders. Okay, so I have no financial disclosures. So Sarah went over this a little bit, and you'll recognize this picture. We all seem to use the same picture because it really demonstrates everything nicely. But I'm going to just review everything in a little bit more detail than Sarah did. So I'm going to start from the bottom, and I'm going to work my way up. As you can see here, we have our uterus and our ovaries. And what we're going to talk about, we're going to refer to the veins around the uterus and the ovaries as periuterine or transuterine veins, okay? Moving up the belly, we have our iliac system. Oops, sorry. Sorry about that. We have our iliac system. So we have our internal iliac, we have our external iliac, which confluence to form the common iliac veins. The common iliac veins confluence to form our cava, our inferior vena cava. And those are the central veins. Now I wanted to talk about the iliac system. I'm actually going to present a very little piece of the iliacs because Mariah is actually going to give us a longer talk about the iliac veins. And the reason we're doing that is because it's important to realize that the iliac system can be assessed outside of the setting of pelvic venous disease. We want to make sure you realize we can look at it during a pelvic session, but also just to check for compression affecting the lower extremities. So we're moving up now, we're going to take a peek at our ovarian veins. You can notice that as they originate down at the ovaries, we're going to see that it's multiple branches and multiple trunks. And as you move up the abdomen, we're going to notice that they become join in to become one trunk. Sometimes it's two, sometimes even three, but typically we can identify at least one of these trunks. And that gets larger, so we can go ahead and see it easier. And you can do that right around the umbilicus or the belly button is where you're going to start to notice that all those little trunks come together. Note on the right side, we can see that that right ovarian vein lies fairly close to the IVC in comparison to the left ovarian vein. And that right ovarian vein drains directly into the IVC, which is different than the left ovarian vein. And as I said, it's a little bit more removed to the left side of the abdomen. You would find the aorta running in between the IVC and the left ovarian vein if the arteries were displayed in this image. And that left ovarian vein, rather than draining directly into the IVC, it has to take the course of draining into the left renal vein, which is what brings that left renal vein into our picture that is pelvic venous disorders. So as Sarah mentioned, there's two etiologies for pelvic venous disorders, one of which is the lack of valves, of competent functioning valves, and that's typically seen in the ovarian veins as well as the iliac veins, specifically the internal iliac veins in the case that we're talking about. And then second is from an outflow obstruction due to an extrinsic compression, and that usually involves the left renal vein or any of the iliac veins. And like Sarah said, it could be a combination of both, and honestly, I know that I typically, in my experience, there's usually a combination of the two things happening. So before I even get started, I do want to point out this paper, a standardized ultrasound approach to pelvic congestion syndrome. And that was written by Nikos Labropoulos a few years back in 2017. And any of the ultrasound images you see, or not ultrasound images, photos you see of probe placement actually came directly from this article. So I want to give him credit for that. So let's start talking about the veins in the pelvis and how do we assess them. So there's two different ways to assess the veins in the pelvis, transabdominally as well as transvaginally. So I'm going to present on both. So we start out using a 2 to 5 megahertz curved linear array transducer. You can see the probe placement is just below the belly button, right above the symphysis pubis, and it's where your full bladder would be. Patient prep is nothing to eat or drink for 8 hours, and that's to help with the abdominal portion of the imaging. And then for the transabdominal pelvic portion, we need 32 ounces of water for a full bladder. And we just have the patient start drinking that and finish it about a half an hour before their study is supposed to start. And that way they come to the lab with a full bladder. If that's not the case, you can check the bladder intermittently throughout the study, but move on to the next piece of anatomy and then revisit that. But once the bladder is sufficiently full, it's probably pretty uncomfortable for the patient. So once you get your images that you need, you're going to want to let them empty their bladder so they're comfortable for the rest of the study. So I really want to go over real quickly just normal pelvic anatomy, because I think this is what might keep vascular technologists from wanting to venture into the pelvis, because we're not very familiar with the organs. So this is just an ultrasound picture of the of the normal uterus. This is our big bladder here, giving us a nice acoustic window. You can see the body of the uterus, the cervix, and the vagina. And this is a longitudinal image. And then we're going to go ahead and switch over and look at the cross-sectional image or transverse image. And again, the bladder's there. We can see the uterus in the middle, highlighted the endometrium there, but not much that we need to know about that. And then the ovaries on either side within the pelvic adnexus. That being said, if you ask most general ultrasound techs, it's a happy day when you can see the ovaries that easily. So let's talk about diagnostic criteria when we're evaluating the pelvic veins transabdominally. It's the veins need to be 5 millimeters or greater. That being said, we really just got that criteria. So for the first few years that I know that we were doing this, it was really, if you could see veins in the pelvis, they're abnormal because the veins are very small. First image is showing a absence of enlarged veins. The middle image is showing what we know of as veins in that left adnexa and a few peeking out on the right side. So I suspect if with a different angle, we would see more veins on that right adnexa as well. And then there's just a color flow image demonstrating flow within those veins. Now, what we want to do, make sure we do, is that we put our Doppler in these vessels, because at that, you notice in that other picture, they just look like cystic structures. So we need to confirm a couple things. Number one, we need to confirm it's vascular and venous. And then we also want to just make sure that it's not a cystic structure such as an ovarian cyst. And you want to evaluate these veins with your scale very low. They're very slow flow vessels. So you want to decrease your scale, and you can have the patient perform a Valsalva maneuver. And as Alita said yesterday in our session, when the patient bears down, it lights up just like a Christmas tree. It's really impressive imaging. So now we'll move on to the transvaginal portion of this. So patient prep is the same as far as NPO for 8 hours. The nice part is they do not have to have a full bladder. Patients lying down with their feet in stirrups. I've never had stirrups on my exam table, so I just have them bend their knees and put a pillow under their hip or lower back, and it just tilts the pelvis nicely for you. This is a transvaginal probe for those of you that don't do these studies very often. You can see the probes inserted into the vagina, and this is the view you get when you're in a longitudinal. And of course, you can turn the probe and get some nice cross-sectional images as well. This is just normal anatomy within the pelvis. This is demonstrating what the uterus will look like in a longitudinal, and here in a cross-section. That first picture is a bit of a zoomed image, just so you can see what it looks like. But when you move to the second picture, you're going to see it's not quite as zoomed. And what we see there are some tortuous, what we know of as vessels, because we've tested that they are. And they're crossing from one side to the other. And those are our transuterine and periuterine veins. So diagnostic criteria for transvaginal ultrasound is veins that are greater than 5 to 6 millimeters in diameter. And that was really important back when we didn't have diagnostic criteria for transabdominal. We could see the veins, so that's how we called it positive. Well, with transvaginal, we could see all the veins, and we know that a 3 millimeter in diameter vein is actually normal. But so that's on the right side, and we can see that quite clearly. And on the left side, we can also see very clearly a incompetent tortuous varicosity, 8.5 millimeters in diameter. This is just a longitudinal and transvaginal with the transvaginal probe. You basically sweep right through the uterus to the adnexas left and right, and you can just see that it's very obvious and actually very nice imaging of these pelvic varices. This is just a quick video clip demonstrating reversal of flow or flow with the patient performing a Valsalva maneuver. And you can see it's really nice. You can see them quite clearly this way. And then the one part I want to talk about with the iliac system is the internal iliac veins. It is the one vessel, iliac vessel, that you can see transvaginally. We can actually see it a little bit nicer than we do transabdominally. So you'd find it by sweeping right through the uterus in a longitudinal out to the lateral walls. You can see that iliac vessel. It lies right along the pelvic wall. And general ultrasound techs will tell you that they often use that iliac vessel as a landmark to find their ovaries. And this is just a quick video clip. It's not the best, it's not the best quality video, but it does actually show us exactly what it is that what we're looking for here. So you'll see the internal iliac vein with normal respiration, and then the patient performs a Valsalva, and we go ahead and we see our reflux there. So All right, so now we've decided that there are varices within the pelvis, so we need to figure out why. So we're going to go ahead and move up the abdomen. If we're using a transvaginal probe, that probe goes away, and we've switched to a 2 to 5 megahertz curved probe. This is the probe positioning for evaluation of the left renal vein. A little bit about left renal vein anatomy. 98% of the patients, it courses between the SMA and the aorta, as you can see here. But in 2% of the patients, it actually can course between the aorta and the spine, and that could be what causes that compression that was talked about earlier, and we're going to review again. Some patients actually have two limbs that cross under and over the aorta, and I have yet to see that, but I have heard that that happens. So diagnostic criteria and protocol for left renal vein assessment. So we're going to get Doppler velocities and diameter measurements at the following points. At the left renal vein on the kidney side, or what I like to refer to as peripherally, at the level of the SMA or suspected compression, and also at the IVC confluence. And that's important to get that third IVC confluence measurement because of what Mariah mentioned about the possibility of stretching versus an actual extrinsic compression. So our Doppler velocities in veins, we don't often talk about velocities in veins. So we need to apply the same rules that we apply when we're looking at arteries for velocities. We have to keep a 60-degree angle at all times. So we make sure we're comparing apples to apples as far as our velocity measurements go. These are some images of a patient who's positive for left renal vein compression. In that first image, we can see more peripherally or on the kidney side, a 10 millimeter in diameter vein. As we get to the SMA and the aorta, where we're suspecting a compression, we have a 1.2 millimeter vein. And then as we move closer to the confluence with the IVC, we have a 3 millimeter vein. So that gives us a diameter ratio of 8.3, which is well over our cutoff of 5. And then we'll move on to our Doppler waveforms, where we can see that our velocity is about 22 centimeters per second peripherally. And then as we move centrally, we have a 256 centimeters per second velocity, which gives us a ratio of 11. So again, greater than 5, positive for a significant left renal vein compression. Just something to keep in mind, as we look at these waveforms within that left renal vein, we can apply the same principles we do when we're looking at the common femoral vein, looking to see if there is spontaneity and phasicity within those common femoral veins, which would, if there wasn't, it would indicate a proximal issue. Same thing with the renal veins. So we can see peripherally on this patient that there is actually static flow. There's no spontaneity. There's no phasicity in that peripheral portion. And that would make me suspect that something might be going on more centrally. And lo and behold, there was. So we went from a velocity of 11 centimeters per second to 239 centimeters per second. So the waveforms are important to look at because it will give you a hint of what you're going to see as you move upstream. So now we know that the left renal vein is or isn't involved in this. So next we're going to talk about the ovarian vein evaluation. So patent position is the same. They're going to be supine with their head elevated to 30 degrees. Transducers, 2 to 5 megahertz, and diagnostic criteria is an abnormal size greater than 6 millimeters in diameter, although there are reports of smaller ovarian veins demonstrating reflux as well. And then we really want to try to demonstrate retrograde flow or reflux if at all possible. So a couple of quick tips about the anatomy of the ovarian veins just to help in finding it with the ultrasound. The distal ovarian veins cross over the proximal external iliac veins, as you can see in this diagram. So if you need a landmark, the proximal external iliac veins is a really nice landmark for that. The left ovarian vein drains into the proximally into the left renal vein, and the right renal vein drains directly into the IVC. And again, just note where those vessels are. The right is more central and the left is a little bit further out to the left side. Probe placement for the left ovarian vein, and just note again how far it is from the umbilicus, and probe placement for the right, and you can see it's much more midline. My favorite landmark to use is the psoas muscle. You can see the psoas muscle here. You can see the beautiful striations of that muscle. It shows up quite nicely on your ultrasound. And then that ovarian vein just courses right along that anterior wall of that psoas muscle. I prefer to find it in the longitudinal, but I know that lots of people find it in the cross section as well. And they'll find that, go to that external iliac vein, turn their probe into a cross section. They'll see a cross section of the psoas and a cross section of that ovarian vein. So these are just a couple images demonstrating flow within the retrograde flow within the ovarian vein. This is a video clip that's going to show you some spontaneous and continuous retrograde flow within the left ovarian vein. You can see it here as I'm following it from approximately down the abdomen. You can see the psoas below it, and that was just demonstrating spontaneous flow. This video clip is a video of the confluence of the left renal vein with the left ovarian vein. So here you see the left renal vein, and here we can start to see that confluence, and then we'll follow that vein down along the abdomen, and we'll see that we have spontaneous flow within that ovarian vein. So how do we elicit reflux in these veins? And this is probably the hardest part because they're actually very easy to find once you understand the landmarks. But how do we demonstrate reflux? So we can use manual distal augmentation down near the iliac fossa, which is very similar to augmenting the calf and the lower extremity. We can use a controlled Valsalva technique, which is a little bit difficult because it's hard to describe to the patient that we want them to take a deep breath in and bear down without actually moving their abdomen. Because when they move their abdomen, it displaces our probe, and then it makes it so much, we lose sight of those vessels. I like to use a position change, use gravity in your favor, just like in the lower extremities. We want to fill up those vessels as much as we can. If you don't have a bed that has a footboard that you can tilt to a very extreme reverse Trendelenburg, you can just stand the patient right up and take a peek at those veins. Just two things to keep in mind as we move on. Sometimes there's spontaneous, continuous flow, just like we saw in that video clip within the ovarian veins, particularly the left ovarian vein. And we're going to talk about why that happens in the next slide. And you also want to make note of any continuous antegrade flow within that right ovarian vein. And again, we'll explain why in a minute. So let's put all these pieces together. And I'm going to apologize for my crude drawings, but they actually, I think that they get the point across. So we're going to start with the bottom and work our way up. So we know that we have some varices within the pelvis. We have overfull veins, and we need to know why. So we're going to go ahead and assess up the abdomen. So of course we can talk about the iliac veins and their portion of it, particularly the internal iliac veins, but I'm going to go ahead and let Mariah do that in our next talk. So I'll move on. So next we're going to talk about the ovarian veins. So this picture demonstrates reflux or retrograde flow in both ovarian veins. What we need to know is if there is particularly in talking about the left ovarian vein, is if there is a significant compression in that left renal vein. And that's really important for two reasons. Number one, what happens is the left kidney will try to, its outflow is through that left renal vein, obviously, to the IVC. Well, if there's a significant enough compression, what happens is that blood from the kidney actually takes the path of least resistance, and it proceeds to go down the left ovarian vein, causing that reflux or retrograde flow. Now, it's important to be able to determine if this is the case or if it's truly a case of just absence of functioning valves in that left ovarian vein, because if we were to go ahead and treat that left ovarian vein without truly understanding the role that the stenosis is playing in that left renal vein, we could cause some harm to the patient. Now, ultrasound can't help determine that for us, but it can give us a few hints. And one of the hints could be that if you have spontaneous, continuous retrograde flow in that left ovarian vein, then that can be indicative of the fact that that left renal vein compression is actually fairly significant because it's a constant retrograde flow versus one that we augment to make happen. So we're going to move on. We're going to talk about what happens when this blood makes its way down the wrong direction down these ovarian veins. So as you can see here with my arrows, the blood's going to go down the ovarian vein. It's going to enter the pelvis. It's going to overfill the veins within the pelvis. Well, two different things can happen, and Dr. Meisner explains these quite nicely. He talks about them as compensated or uncompensated. So let's talk about the compensated first. So what happens is we get this retrograde filling of these pelvic varices, and they manage to make their way out of the pelvis, and it can be, a left ovarian vein issue with veins that cross over the pelvis onto the right side, and they can present themselves in the right groin and the right lower extremity, or just straight out the left side. But what happens when that doesn't happen and we have uncompensated flow? Well, what can happen is the blood comes down, crosses over the pelvis, and makes its way back up the functioning right ovarian vein. And that's where we're going to want to look for an increased diameter of that right ovarian vein, but with spontaneous and continuous antegrade flow. So normal direction flow, it's just forced along by that pressure from the left ovarian vein. So in conclusion, the veins of the abdomen and pelvis can be accurately assessed using ultrasound. It's important to understand the anatomy involved in pelvic venous disorders is all related, so every attempt should be made to assess all the veins involved. And this is particular for that left renal vein. We really do need to know if that's involved before we start treating the ovarian veins. And I just want to say, you know, from an ultrasound perspective, as a technologist, don't be afraid to step out of your comfort zone. Learning something new can be very rewarding, and it's actually, this test seems very daunting, but it actually is quite simple once you get started with it. And again, I just want to acknowledge this paper. I know myself, Sarah, and Mariah have said multiple times that we wish this paper was around when we were learning these studies. It would have made life much easier, so I recommend that you obtain it and keep it in your vascular lab for reference. And I want to say thank you very much from my beautiful hometown of York, Maine. Thank you.